This video will be reviewing the steps for establishing a sacral diagnosis. Our first thing that we need to do is a lateralization test, which for the purposes of the sacrum will be a seated flexion test. Before we can do a seated flexion test, we have to assure that the patient's feet are either flat on the floor or being supported, in this case, by the ladder back stool. So he's resting his feet comfortably on the rungs of the stool. That's going to take the lower extremity out of the equation. Then we're going to contact the PSIS just as we did in the standing flexion test. I'm going to keep my eyes level with my thumbs as best as I can, with my dominant eye over the midline. And then can you bend forward? We're going to see which side moves the furthest overall and is also the last one moving. In this case, it is the left side, which was the positive side. We can do that one more time, nice and slow. So they're both moving here. And then at the end, the left one is the last one moving and also moves the furthest. Okay, so he has a left-sided seated flexion test that is positive. That tells us that he either has a torsional dysfunction around a right oblique axis, or he has a shear dysfunction involving the left half of the sacrum. Next, we're going to have you lay face down with your face up there. Our next test is a lumbosacral spring test. We're going to find L5 and S1 right where they meet. We're going to place the heel of our hand directly over that lumbosacral junction, and we're going to spring up and down. What we want to see is that L5 and S1 can hinge adequately against each other, and he does have spring. I can feel the two segments move as I compress. If so, that means that his spring test is negative. If there was no motion between those two, and the two segments moved together in tandem, then that would be a spring test that is positive. That would indicate a posterior sacral base. His spring test is negative, which means that the sacral base is displaced anteriorly. Next thing we're going to do is check our landmarks. One landmark we can check is the sacral sulcus. If we find the PSIS with our two thumbs, and then move just medially to the PSIS and drop our thumbs vertically into that space, we can palpate and see which sacral sulcus is deeper. In his case, he has my left thumb goes further than the right thumb, so we would say that his left sacral sulcus is deep. And then the final landmark is the inferior lateral angle of the sacrum. For the inferior lateral angle, we're going to place the heel of our hand on the bottom base of the sacrum. We're going to feel two prongs poke out and hit the heel of your hand, which is going to correlate with the sacral hiatus. If we palpate that sacral hiatus, we can move out lateral to that, which is going to land right on the inferior lateral angle of the sacrum. And again, we want to look for which inferior lateral angle is more prominent. In his case, the right side is more prominent. And so based off of those landmarks, a negative spring test, and also a negative seated flexion test positive on the left, that would give him a diagnosis of a right-on-right sacral torsion. One other option that we can do is an alternative for diagnosis is to do a sphinx test. When we do that, we say that he has a prominent inferior lateral angle on the right, he has a deep sacral sulcus on the left, and then we can ask the patient to come up into the sphinx position. And as he comes up on his elbows, we can reassess those landmarks. If the landmark asymmetry gets worse in extension, then he has a posteriorly displaced sacrum. If his asymmetry gets better in the sphinx position, then he has an anteriorly displaced sacrum. And in this case, this again goes along with an anterior displacement, which would be a right-on-right sacral torsion that he has.